On behalf of the University of Iowa Hospitals and Clinics, we thank you for attending today's presentation, When is a Referral to Pediatric Neurosurgery Needed? With Dr. Brian Dlouhy. Our faculty's goal is to share information you can use about the latest therapies and techniques in medicine and answer your questions about how to partner with us in the care of your patients. These are informational presentations to enhance your clinical practices and to provide you the most updated information we have. No CME credit is provided at this time. This program is being recorded and will be posted to our educational resources for referring physicians webpage. We certainly encourage questions throughout the program with the chat function. And at the end, we will also open up direct questions with Dr. Dlouhy by unmuting yourself as well. So at this time, I'd like to introduce Dr. Brian Dlouhy, a neurosurgeon with the University of Iowa Hospitals and Clinics and Stead Family Children's Hospital. So Dr. Dlouhy, take it away.
Oh, thanks so much for the nice introduction. When putting together this presentation, I thought about when to refer to a pediatric neurosurgeon, but also advances in pediatric neurosurgery. What can we do now? I would say neurosurgery and general pediatric neurosurgery is probably one of the youngest fields in all of medicine, and it's a huge growth field, and things are rapidly changing. And I think it's good for referring providers to know kind of what we do, and as they know what we do, then they can have a better idea of when to refer. So I have no disclosures, and I just have some funding for research. So a little bit about myself. My name is Brian Dlouhy, and I'm supported by an amazing wife, Katie Dlouhy, and who's not only my wife, but also colleague. She's also a neurosurgeon here at the University of Iowa. She's an adult vascular neurosurgeon. We met many years ago, and then she finally joined here in Iowa City this past year. We're very fortunate to have a brand new baby boy, and born about 4 weeks ago now, and Aiden James Dlouhy, and this is the first photo of him after being born here at the University of Iowa. And this is a bath picture. We just thought this was a funny picture. He's either stretching or he is dancing, but so he's getting off to a good start. So to tell you a little bit more about myself and my journey and how I got here, I was born in Tampa, Florida, and I went to the University of Florida in Gainesville for college. Majored in engineering, and then I decided I wanted to go to the biggest city possible. So I went to New York City for medical school, and I went to medical school at NYU. And then for residency, I came to the University of Iowa, and that was in 2007, did my training here. I then did a fellowship. Actually, first I did a fellowship in Australia for 6 months, a minimally invasive neurosurgery fellowship with a pediatric neurosurgeon there. It's highly regarded. I then went to St. Louis Children's Hospital for my 1-year pediatric neurosurgery fellowship. And I came back to the University of Iowa as faculty in 2015. So I'm not the only person here, obviously. We've had an incredible lineage in terms of other neurosurgeons and pediatric neurosurgeons who've come here. Dr. Meneses has been here for many years and still practices here. He's kind of one of the original master neurosurgeons and sort of created, the field of pediatric neurosurgeon with about 15 others in the early 70s. I work with Dr. Saul Wilson, who's a great colleague of mine. And importantly, what's been established is we're all certified as the American Board of Pediatric Neurosurgery. Requires an oral board presentation and a written examination as well. So for contact information, how can people get a hold of me? My email, patients email me, other providers email me. It's easy. You can email the other providers as well. And you can call or text me on my cell. I didn't provide it here, but that can be given later. And then referring a patient to our department, how do we go about doing that? And so these are numbers we can telephone and fax. And I'm in pretty close contact with our referring provider a liaison here who kind of organizes that. So in general, what are the conditions that we treat? There's a whole bunch of them. And obviously I can't go through every single thing. And neurosurgery has become such a massive field that it's hard to go over everything. And hopefully at the end, I can answer some questions, or if people can email me But I figured I'd go over some of the main things here on the left-hand side. So hydrocephalus, craniosynostosis, brain tumors, Chiari malformations, epilepsy. I'm also be talking about a tethered cord and somewhat spasticity. So one of the biggest things that we get referred to in pediatric neurosurgery is macrocephaly. And there's many causes, and that's why there's so many patients are referred. Many of them are benign. And that's typically just kids have larger heads. There's genetic causes and just familial, and it's very benign. What drives the growth of the skull is the growth of the brain. And so those children, their brain just growing a little bit faster for their age group, but typically benign. There's also something called benign extraocular fluid collections of infancy, or benign enlargement of the subarachnoid spaces. This is a little bit of extra fluid around the brain. It also can be in the ventricles, but doesn't cause excessive pressure. And these patients don't need any other surgery. They just need to be watched. And we watch a lot of these because they can kind of mimic the more concerning diagnosis of hydrocephalus. Hydrocephalus is increase of fluid within the fluid-filled spaces of the brain, and specifically increase in the ventricles. So those deep-seated fluid-filled spaces, and the pressure there then increases on the whole brain, enlarges the skull, and ultimately needs treated with some kind of surgical procedure, a shunt or an endoscopic type procedure. Other things that can occur are mass lesions, tumors, other congenital lesions as well. So what's the big concerning thing, and what do referring providers really need to look out for? And that's hydrocephalus. Obviously, this is a neonate there on the left and has pretty obvious signs that something's going wrong. We have the frontal boss, an enlarged head, and in a lot of cases, they'll have sundowning eyes and other things too that you'll pick up on that I'll go over in a second. There's many different ways to image hydrocephalus in a young baby, and neonates, their open anterior fontanelle allows a nice view via ultrasound, and it's really non-invasive, and kids can tolerate it quite well. Then there's obviously the head CT and the brain MRI. Now we've gotten away from really doing CTs in young kids just because of the radiation reasons. So we'll get a quick scan. Axial T2 is just one sequence, which you can see here. And that allows no radiation, no sedation is really required. Kids can tolerate that quite well because it's so short. That allows us to kind of get a quick image of the brain. MRI gives more detail than CT as well of the actual brain itself. So hydrocephalus, what are the symptoms? Well, neonates, and I divide this up with neonates and then kind of greater than 1 year of age. But neonates with an open fontanelle and sutures are very different than someone that has really a closed fontanelle, someone that's older than a year. So they'll get macrocephaly because obviously the sutures are open, and so they'll increase the size of their skull, and can be quite rapid. They'll cross percentiles, right? So they'll cross 2 percentiles quickly within 3 months. Obviously, oftentimes they'll have this down gaze preference. The eyes will only look down. They won't be able to look up. We call it sunsetting eyes, and they'll be developmentally delayed. Now, greater than 1 year of age, now when those sutures close, the hydrocephalus isn't going to necessarily enlarge the skull. So kids can be fussy, irritable, headaches, vomiting. Can be lethargic, and they'll definitely have developmental delay. So what's the big concerning thing when we look at these kids that have this macrocephaly? They're trying to really catch someone that has hydrocephalus and not miss that, right? So the growth chart, we talk about the OFC crossing percentiles, whereas weight is not. So obviously some kids they're crossing percentiles even with weight. So there's a big kid. So they may be 98 percentile in weight, and their head circumference is only 99 percentile. The chance that and they look very proportionate. The chance that they probably have hydrocephalus is probably pretty low. Now, if you have a kid that is 10 percentile for weight, or even 20 percentile or 50 percentile, yet their head circumference has gone 99 percentile and it keeps going up, then there's concern. And obviously a lot of these kids that the pediatricians will see, they won't have the hydrocephalus. They'll have this benign extraocular fluid collections, and we rule that out with an MRI, that quick scan axial T2 that we typically get here in our clinic the day they come in. That really helps rule things out. But there's some subtleties that they can help their pediatrician to figure these things out in terms of is this really concerning. I mean, really that kind of bulging fontanelle and then really the splaying of the sutures. And again, those symptoms above will kind of help in those neonates. Can be a little trickier, obviously, than when you're greater than 1 year of age. But if there's any concerns, I always say, ask us, ask me, email me, and don't hesitate to refer for patients. And I don't really think our referring providers do hesitate, so that's good. There's many causes for hydrocephalus, congenital causes, where there's just an obstruction. It's within those fluid-filled spaces deep in the brain. Hemorrhage that occurs, infections, tumors, etc. And we treat this obviously with a shunt or endoscopic methods. And I'm gonna go over kind of the techniques that we use. And premature infants, they're too small to have a shunt, so we have a Meyer reservoir, and we just we place a catheter that goes into the ventricle and a little reservoir that sits underneath the scalp, and then we could tap this percutaneously to drain off CSF kind of every day or as needed. Now, when kids are older and usually greater than 2 kilograms, we'll do a shunt. These are the deep ventricles in the brain. They're exerting pressure on the outside of the brain and will cause damage over time. So, we place this shunt, which again is this catheter that goes in to the ventricles. It goes to a little reservoir and then to a valve. And this is one of my patients that has a same thing, has this little catheter that goes deep into the brain and has a little valve and has a tubing that goes all the way down to the peritoneal cavity, as you can see here on the right-hand side. And this will drain in the peritoneal cavity, and that peritoneal cavity is also producing fluid every single day. And that peritoneal cavity will be able to absorb the CSF. We usually use programmable shunts. Sometimes we don't, but most of the times that we do, we can change the shunt settings to drain more fluid or less fluid, just based on the individual need of the patient. Other techniques, and usually this is reserved for a little bit older kids, usually greater than 6 months, and really more importantly, greater than 1 year of age, and that's the endoscopic third ventriculostomy. Patients will have a blockage here somewhere in these fluid-filled spaces and these channels. And instead of doing a shunt, which has complications, right? It's a foreign object that you place in the brain that can get infected, can get obstructed. An ETV does not get infected, and it doesn't get obstructed very often. So we use a small laparoscopic camera that goes through a small burr hole in the skull and small incision. And we shine, basically, you're showing here, we're shining light on this floor of the third ventricle, and then we can poke a hole through that. So you're bypassing these blockages of pathways that can occur in the back part of the brain, and then we're draining directly into the subarachnoid space here. So, I mean, as I'm going to talk about a lot today, a lot of things, the neurosurgery goes more minimally invasive. What can we do that's less invasive that's been done in the past? That's going to cause less morbidity and better outcomes. So the other topic is, craniosynostosis or abnormal head shapes, plagiocephaly. And this is a normal cephaly here. This is a normal child with the normal sutures. The sutures typically fuse at different points in life. And the skull is, the brain is rapidly growing, like I said, in the first year of life. It grows the most in the first year of life and the second most in the second year of life. And what drives the growth of the skull is the growth of the brain. And if one of these, and so it requires all these sutures to be open to allow a normal head shape, right? So if one of these sutures here is closed early and fused in utero, like the sagittal suture in the midline, the skull will not be able to grow in width, right? It can only grow in the front to back. And so you get this scapulocephaly, this head shape, the skull shape. And that's called sagittal synostosis. If you get a fusion of the metopic suture too early, then you get metopic synostosis. And then a coronal suture, you get a unilateral coronal synostosis, same thing for lambdoid. Now, kids are also, with the Back to Sleep campaign, now lying on their back and going to sleep a lot more. That puts this kind of pressure back on the back part of the head and can deform the skull. And there's ways that I can pick up on this. And most of craniosynostosis is a clinical diagnosis. I could look at a child and say, yes, that's sagittal synostosis, that's metopic, that's positional plagiocephaly. And how to determine that can be challenging. And I just don't rely purely on my clinical skills. I often will get X-rays, and we'll sometimes even get CTs if there's even some concern. Because this is not something you really want to miss. Not in, what I say always is, not in 2020, not with the kind of medical and healthcare system that we have now, should you miss, craniosynostosis. So, for plagiocephaly, referring providers, they can get X-rays if they want and see what the radiologists say. If there's any concerns, I can take a look at them. It won't take that long for me to kind of look at the sutures and say, oh yeah, we should see that child or not. Because sometimes even the radiologists can be stumped, and even they, have a hard time sometimes. So And what do we do for craniosynostosis, right? In the past, we've done these open, large incisions, and we do these cranial vault reconstructions. If referred early enough, now we have more minimally invasive options. We use, again, the endoscopic approach that we use for that endoscopic thoracoventriculostomy. We do the same thing for craniosynostosis. We use a small camera that helps us dissect underneath the scalp and underneath the skull to only just remove the suture. That's the problem, right? So these kids have these sutures that are fused early. Now, all you have to do is remove that suture, reopen up and reestablish the normal open pathway so the skull then can grow instead of being restricted and growing, medial and lateral and width for something like sagittal synostosis. Then if we take that suture out, then over time, then the brain will continue to drive the growth of the skull and drive it in a more normal fashion. That's what's called this kind of endoscopic assisted minimally invasive craniosynostosis repair that I'll talk about in a second. These are the different appearances. Sagittal synostosis can look like some molding that can occur from passage to the birth canal. But sagittal synostosis only get worse as a child ages. The molding and when a child has gone through the birth canal will get better over time. Metopic synostosis or creates this trigonocephaly type picture where you see this triangular head shape. And then coronal synostosis is an interesting one, and it can be severe depending on how early. And all these can be differences in severity depending on how early that suture was fused. So as coronal synostosis, you'll get this kind of an enlargement on the opposite side of the fusion. So basically a frontal bossing the opposite side of the fusion. That sometimes will close the eye. And the other side is flattened. As you can kind of see here, this area is flattened. This is frontal bossing. This eye will be a little bit smaller and closed. This eye will be a little bit more opened up. And this will worsen over time. So we've gone more, in the last, I'd say, year and a half to doing more of these, minimally invasive endoscopic assisted techniques. And this was a kind of a write-up that was done recently in our medicine Iowa of a child who at the age of 2 months of age, or really kind of at birth, was diagnosed with with coronal synostosis. And at 2 months of age, underwent our kind of endoscopic assisted minimally invasive technique, where you see this kind of fused coronal suture here. And then we basically use a small incision, about 1.5 centimeters. And then we take this endoscope to dissect the skull from the dura. And then we remove that bone all the way down to the squamosal suture here. So this opens up entirely. And then afterwards, we use this helmet that helps remodel the skull. Sort of what we do with deformational positional plagiocephaly. So this is another case of sagittal synostosis where we remove this strip of bone from front to back, and here's a 3D reconstruction of the brain immediately after we did the surgery. It goes all the way back to the lambdoid sutures and all the way to the front, so the anterior fontanelle. And then we use this helmet postoperatively to kind of remodel the head shape, as you can kind of see here in this process. And this child's still wearing this helmet and regoing this modeling, but you can see the comparison from immediately after surgery to just 6 weeks later. So what's the key to doing this minimally invasive endoscopic assisted technique? Well, the key is that these patients have to be referred early, because this surgery relies strongly on the growth of the brain to remodel the shape of the skull with the help of an orthotic helmet. As I mentioned, the brain grows the most in the first year of life. So if you wait till 7 months to do this surgery, there's not much time left for that brain to really drive the difference in the shape of the skull after this kind of surgery. Now, if you did this, say, a month or 2 months of age, then you can take the whole year. The brain's going to grow so much, it'll reshape that skull in an incredible way, especially with using that helmet postoperatively. So ideally, this surgery for all those, for the metopic, the sagittal, the coronal, the lambdoid, and even some more syndromic cases, surgery should be done 3 months and younger. Actually, really, ideally, I try to do these 2 months of life if we can, because we get less blood loss. There's often no need for transfusion like the older, bigger surgeries. GCRIS hospitals say they're only there for 1 or 2 nights because there's so much less swelling. They tolerate it better. The operative times are significantly less, where it would take hours before. This takes an hour to do. There's less anesthesia, which we think may have a better outcome in terms of development of the brain, and cosmetically better. We're using small incisions to do this. And I would say that the response from patients is overwhelmingly in favor of this. This is a team approach. As I look at everything that I do, I look at it at a team. I think that more eyes are better than just mine, right? And so, we're all engaged in treating synostosis here at the University of Iowa, and especially in this more minimally invasive approach, Dr. Wilson and myself, as well as our Dr. Meneses, and our plastic surgery and craniofacial plastic surgery team of Dr. Deborah Kakarinsky and Dr. Mark Fisher, to really, I think, treat these patients to get the pure overall best outcome. A lot of these children will need other surgeries, maybe more severe cases. They may have mid-face regression that will need advancement going forward, and other things that I think being tapped into to this craniofacial team, I think benefits that. So in pediatric brain tumors, let's talk about that next. So it's the most common solid tumor in children, amazingly, and horribly at the same time, right? Second most common cancer in children is number 1 is leukemia. It's the second leading cause of cancer death in kids 0 to 19 years of age. Okay, and so important for us as a pediatric neurosurgeon is the location, right, of this tumor, and what it causes and the symptoms that it causes based on location. So location determines everything. What symptoms occur, what signs or neurological evidence are found on exam is where the tumor is located in the brain. The ability for surgical resection, in some cases a cure, depends on where the tumor is located. And then what neurological deficits we would expect postoperatively based on the tumor location. So every part of the brain has an important function, right? So that's why a tumor in the frontal lobe might have a different effect than a tumor that occurs in the posterior fossa and the cerebellum. And so how kids present is going to depends on where the tumor is located. So they may present with headache, nausea, vomiting, balance problems, visual difficulty, seizures, weakness, sensory changes. Okay, there's a huge variety of things that can occur. And what do we see on exam? And I would say we get a lot of referrals because kids have visual problems, right? And they get a routine eye exam, and they find they have swelling of the optic disc. So we get a lot of referrals from ophthalmologists, or pediatricians will send to ophthalmologists because kids have visual problems. They'll see a swollen disc. They'll say, let's get an MRI. That shows a tumor in the posterior fossa causing hydrocephalus and edema. But our patients will also get decrease in motor strength if that tumor is in the motor area, loss of sensation in the face and body, increased reflexes. If there's a pituitary type tumor, they have hormonal changes and growth retardation. And what age can kids get brain tumors? Any age, young as an infant, and congenital tumors in 3 months of age, and even tumors you see immediately after birth to teenagers, right? And so what's the treatment? We use surgery, chemotherapy, and radiation as we go forward more and more and more. Ideally, try to get as much of this tumor out as possible. And then chemotherapy and radiation can work. And who's a candidate for surgery? Anyone with a brain tumor. But also depends on location and suspected type of tumor. There's many surgical approaches. The endoscope we've used for the endoscopic third ventriculostomy to treat hydrocephalus. The endoscope that we've used to treat craniosynostosis. We use the endoscope to treat brain tumors. We use even specific tumors deep-seated in the brain that it's really, really beneficial for. Become a standard of treatment for pituitary tumors as endoscopic approaches, as well as tumors that are in the third ventricle and deep within those ventricles. There's a huge list of tumors that can occur in peds. And these are just some of them. And they all occur in different parts of the brain. One of the most common tumors in kids, they occur in the cerebellum, the posterior fossa. And so this is what we describe as the kind of the part of the midline syndrome in kids. They'll get headaches, they'll get emesis, they'll get balance problems, they'll get lethargy. And they often present with hydrocephalus, which leads to all of these symptoms. The thing that I saw, and even in my fellowship, is that these GI symptoms, these symptoms can be very confused with just a GI problem. A lot of them are GI symptoms, right? The emesis, not wanting to eat, they'll be a little lethargic. They think they're not eating as much, so that's why they're lethargic. They get balance problems. Well, they've lost weight. They get a headache. Well, that's just associated because, wow, they're malnourished now. So these can often be diagnosed as a GI problem, not a brain problem. They'll see a GI gastroenterologist for a long time. And sometimes, it gets to the point where it's almost too late. So that should be recognized. So any of those signs, if you think you're referring to a GI specialist, well, think of the brain too. Here's just two cases, right? So this is a 4-year-old girl with headaches, nausea, vomiting, balance problems. This is your classic posterior fossa tumor, right? And they're all, seems like all of them, they're not small. They're all these huge, massive tumors that are putting pressure on the brainstem and all these critical structures. It requires a very delicate surgery to treat these. Amazingly, with all the techniques that we have today, these kids can do quite well. 1 year post-op, and this kid now, I just saw this kid in clinic last Friday, now years out without a recurrence. This is a complete surgical resection, has no deficits. You can see the hydrocephalus is gone, no need for a shunt because we took away the tumor and they open up the pathways for the CSF to flow. And this is a polycystic astrocytoma, and likely this child won't need anything else. This tumor will likely not come back. Now, tumors are not in the posterior fossa or in the cortex. A variety of symptoms can occur. And oftentimes they can cause those headaches, the weakness, any kind of whatever function that occurs in that part of the brain that can be affected. But also they can cause seizures, right? And they can even cause epilepsy, right? Recurrent seizures, and a variety, again, of these neurological deficits. There's a 3-year-old girl with headaches, lethargy, tiredness, weakness, inability to get out of bed. If she had headaches, they thought it was migraines, right? That's another something you don't want to miss. But it got to the point where she couldn't get out of bed the morning that she presented to us, this massive tumor with this big cyst. This is a huge cyst, and then she had hydrocephalus. We took her for surgery that day that she came in. She's now many years out from surgery without a recurrence. This is a scan from 1.5 years later, doing great, no recurrence. Tumor's gone, no need for a shunt. This is anaplastic ependymoma. It's a pretty aggressive tumor. We're watching her very, very carefully. She did get radiation afterwards. A very common thing that pediatricians will see in their practice and is concerns for tethered cord, right? So you see these dimples in these kids, and almost every kid will have a little dimple at the base of the coccyx. I mean, even my kid has a little tiny thing, and some are more than others. The most concerning thing with these tethered cords is, you're looking for these skin lesions and so forth, and on the lower back, and anything that's really above the gluteal cleft. These are two examples I show here. That's what you're watching for, right? So this is a hemangioma, a little bit of a raised part of the skin. This is a different case entirely here. I'm showing that's with this really enlarged fat pad, and that's a part where your concern is there's some kind of lipomatous mass that's there that's probably connected to the spinal cord. And that's what you see here. This is the MRI of this child who got this MRI at 3 months of age. You see the cord is not supposed to end here. It's supposed to end at the typical L1, L2 level, but in development, these are congenital lesions in development. The spinal cord did not rise up where it's supposed to rise up to L1, L2 up here. It's stuck and it's tethered to this lipomatous mass out here. So this is a lipomyelocele. You can see a defect in the bone that's here. So it's a classic type of a spina bifida as well. The cord's tethered. This child will ultimately guaranteed will develop neurological deficits. Almost guaranteed, I should say, because that cord is so stretched and so tight, and it's tethered to that skin. So the child develops more tissue and more skin. It's going to pull on it more, as well as the child that gets taller. That's going to stretch the cord even more, and then it can lead to sensory deficits, motor deficits, and so forth. So these symptoms you're going to watch out for, because sometimes we don't have those typical skin stigmata of tethered cord. So any kids with urological issues, lower extremity weakness, scoliosis, walking on their toes, you're thinking there's something that could be wrong in the spinal cord. This could be that young baby that's in development. This can even be an older teenager. We even see adults with tethered cords. We've seen first-time presentations of 60-year-olds with tethered cords that went undiagnosed. They have these small symptoms they've had their entire life, but no one did, and they weren't severe enough to really for them to really be concerned about to seek medical attention. They might have some neurological issues, but it wasn't that bad. So again, just things we want to pick up as early as we can. Any concerns, let us take a look at it. Just send us a picture. Talk to me about it. Oftentimes these dimples that are below the gluteal cleft or the base of the coccyx, you can put your finger there and you really kind of feel the base of the spine. We call those coccygeal pits. Oftentimes there's really nothing of significance there, and they don't really have tethered cords. Signs, so again, hairy patch is also another common finding on the back. Above the gluteal cleft is hemangioma, abnormal gluteal cleft, dimple in the lower back, fat mass in the lower back. Okay, those are things you kind of want to refer us to neurosurgery. Spasticity can be confused even with tethered cord. You're concerned about ongoing spinal cord problems too, but oftentimes spasticity is associated with you're going to see a kid that has other problems, right? They have cerebral palsy, and they've developed spasticity as they've aged, and it's only gotten worse, right? So these symptoms that you're going to see, they have tight tendons in the arms and legs. There's that means spastic quadriplegia, and there's spastic diplegia, which is typically just the legs. They get lower extremity weakness, abnormal gait, pain. It's progressively will get worse. Not treated, even into adulthood. This can be very disabling. Can lead to having to use crutches, wheelchair, and so on. It affects the joints significantly. People develop contractures, and will need multiple other orthopedic procedures as well. What are other signs? Increased reflexes. One kid I treated for spasticity, mom called her thumper, because when she was younger, she'd have this, she'd pull the foot up and it would just beat, 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 beat. Clonus, right? But that was a sign very early that there's something wrong, right? Decreasing flexibility. So these worsening contractures in the patella and the Achilles, abnormal gait, toe walking, and that's really this key, this kind of crouch gait. It's going to get worse, toe walking. And there's many ways to treat spasticity. One of the best ways, and I'm bringing this out because we get some referrals, but I don't think we get enough, is we can do a surgery that will absolutely eliminate the spasticity in the lower extremities. That's a selective dorsal rhizotomy. This is pretty much permanent in terms of eliminating the spasticity. It's an incredible procedure. It's small in terms of what we do. We say to do multi-level laminectomy to do this. Now we just do this through a single level laminectomy. I learned this from kind of the expert in this in St. Louis Children's, who's done 4,000 of these surgeries in his career, more than anyone, not even close. Anyone's done more than that. I learned his technique, and that's shown here. The surgery can be quite beneficial. What we do is we section essentially 2/3 to 3/4 of the dorsal rootlets that are causing spasticity. So we're monitoring these rootlets after doing a laminectomy at the level of the conus. So all the way from L1 to S1. And we're monitoring how spastic these roots are by stimulating them. And then we're cutting the most spastic ones. So 2/3 to 3/4 of them are cut. Amazingly, you can cut these and children will not have any kind of sensory deficit. They do quite well. Their spasticity is eliminated right after surgery. They'll get rehab, which is part of that. Might have orthopedic procedures, but a quite an effective procedure. For someone for a child that's ambulating, having a back of the pump is okay, but this would be a much better operation. So something to think about. Obviously, we do back of the pumps here. We do the rhizotomies, and we have other ways to treat this non-surgically too, with Botox and other therapies, including oral baclofen. So something that we do a lot of here and we're well known for is Ara Meneses, is kind of a world expert on Chiari malformation disorders of the craniovertebral junction, and something that I'm very interested in as well going forward in my career is picking up where kind of he's taken this. So Chiari malformation, 4% of the population will have herniation of the cerebellar tonsils greater than 5 millimeters below the foramen magnum. That's a huge percent of the population. Not everyone's symptomatic though. So maybe 10 to 20% of the population are going to be symptomatic from the Chiari malformation. So what's a Chiari malformation? Well, it's the descent of the tonsils below the opening in the foramen magnum, right? So this white line is the opening in the foramen magnum. Tonsils are herniating below that. And they're causing, in this case, a quite severe brainstem compression and a syrinx, this white in the spinal cord. That's what the cerebellum should look like. That's normal, right? We don't have the herniation through the foramen magnum. There's no compression of the brainstem, and the spinal cord looks totally normal, right? This is kind of a blown up view of what is a Chiari malformation. So I did this white box around the blow up of the posterior fossa. This is the brainstem. Look how much pressure is putting on the brainstem. The herniation of the tonsils. This is pushing the brainstem, which should be up here, all the way down to here. Okay, that's what you get, this little buckle of tissue. And you can see that typically it's not thought to be an abnormality of the brain. It's thought to be an abnormality of bone. You can see that this bone kind of hooks in here, and kind of limits the space in the posterior fossa. So there's not much room for the cerebellum to sit here, so it herniates through, blocks the typical flow of fluid through the fourth ventricle. So it's a congenital development abnormality, occurs before 5 years of age in everybody, okay? Rarely changes over the course of a life. Patients can present from 1 year of age, or even less than 1 year of age, which we've seen, to 70 years of age. Symptoms are extremely varied. The most common is a headache. I keep a database of all our patients we've treated here over the many years from 2003 till now. We've done 467 Chiari surgeries since that time, from babies all the way up to 67 years of age. Okay, so it's incredible the varied presentation can occur. The most common symptoms are these suboccipital headaches. They're brought on or worsened by valsalva maneuvers: coughing, sneezing, laughing, crying, straining, exertion, playing outside. Obviously, kids will get migraines. It's hard to rule these things out, but this classic, it's right back here. That pain that can radiate down the neck or radiate forward to the front of the head. Okay, it's not typically brought on by sounds or lights, bright lights. There's no aura typically associated with it, unlike a migraine, right? And then in young kids, this is key, right? So very young children present a little differently than older kids and in adults. They may fail to thrive because they have swallowing difficulty. That pressure that gets put on the brainstem, they can't swallow as well. They don't gain as much weight. They can be malnourished, right? And oftentimes these kids don't complain about a headache. They don't know how to. They don't know how to communicate with us. They're so young, so it's difficult to express a headache. This may translate really as constipation, abdominal pain, right? With bowel movements, they have to use their Valsalva maneuver well. So they may become constipated and then develop abdominal pain instead of really headaches. Other symptoms. So I described the swallowing difficulty that can occur in anybody. They may cut their food into smaller pieces, right? So they may adapt. These kids and these adults, they may adapt to the Chiari malformation, right? They found ways around the symptoms that they've had, right? Snoring, sleep apnea, both obstructive and central sleep apnea, hoarseness, decreased gag response, scoliosis, right, is another one that can be caused by a Chiari malformation from a syrinx or just from pressure on that brainstem. And there's many other symptoms that can occur because the cerebellum, and we're learning more about this, and part of my research is studying this. It plays a huge role in many cognitive processes, but it's been understudied for so many years. So what's the treatment? Well, you can observe it, surgery. There's going to be medical and lifestyle changes. Typical surgery is a posterior fossa decompression. We remove the back part of the brain here in the over the cerebellum, just over the foramen magnum. In some cases, we have to open the covering of the brain. We do a lot less of this these days. Each patient is treated individually. Some patients will get just a posterior fossa decompression and removal of the outer layer of the dura without having to open the dura. Some cases we have to do more than that. Some cases we actually open the covering of the brain, take away all these adhesions and scar tissue that's formed, and then do a patch of their own tissue to make a little bit of a bigger space, so there's more room for that fluid to flow. And here's just that case I showed before, pre-op and post-op. And the post-op changes occur over time. This is not immediately after surgery, but a year after surgery, you see the syrinx completely gone. There's no more compression of the brainstem. We have our epilepsy practice here for the adults and kids is growing, especially in peds. And that's a big focus of mine, both from research standpoint and clinically. The incidence of epilepsy is highest in children and older adults, as you can see here, right? So this should be something on every pediatrician's mind. As I mentioned before, tumors can cause seizures, and it can cause recurrent seizures in epilepsy. So these are things to think about. Or seizures can just be from epilepsy and really not a tumor. There's congenital things that occur in the brain that causes this. And so why be aggressive in treating epilepsy? For a long time, there's seizure, a couple of seizures a year, that's not a problem. Well, what we found is that even just a couple of seizures a year can cause cognitive decline, loss of brain function and memory and motor skills and language. IQ is directly proportional to linked to refractory epilepsy. So if you're having recurrent seizures every year on medications, that's called medically intractable epilepsy, right? And epilepsy is like a cancer. It starts in one location, it's going to spread to other parts of the brain. And if you don't stop those seizures, it's going to continue to spread. And over a lifetime, it will spread to many other areas to the point where it's not treatable and it gets worse. In kids, the poor development, they get loss of awareness and alertness in everyday life. Like I said, worsening seizures, and they can lead, they have research of mine that I've studied as SUDEP. They can lead to sudden unexpected death in epilepsy because they stop breathing during seizures. And it's a very common first presentation in young kids. So who's a candidate for epilepsy surgery? I say anyone with epilepsy. but they have to go through the typical channels, which is seeing our pediatric neurologist and getting worked up for epilepsy. If medication works, then yeah, we don't need to do surgery. So there's many other things I could talk about, but I can keep go on and on and on. But and maybe there'll be another time to discuss other things. But those are some of the biggest areas I think, and referring providers, would want information for. Again, this is my contact information. This is my email address. You can get my my cell and call or text me. And this is where you can refer patients here for pediatric neurosurgery. So thank you, and I'll take any questions you guys have.
One of the questions I had, Doctor, is with the Chiari malformation, if a parent has had this condition and a couple of children, they're suspicious of this with their own children, should these children be screened in any way, or do you wait for symptoms to develop?
Yeah, that's a great question. There are some cases of Chiari which appear to be more, hereditary in the family. It's not autosomal dominant or even autosomal recessive. Okay, because the genetics of Chiari malformation is extremely complex. But I've seen, there's a mother and a child will have almost the identical looking radiographic Chiari abnormality. So what I typically say, and it's about 10%, they've done studies, and about if one person in the family has it, the chance that another family member has it is 10%. So typically I say if they have symptoms, get imaging. If they don't have symptoms, I would say wait till symptoms occur, but those symptoms can be very subtle, and that's the key, right? So, I'll pick up things on exam that maybe someone else hasn't picked up, right? Like when I look for the gag response, I'm sticking the tongue blade all the way back. I'm looking for, is there a really strong response like there should be, right? Especially in a kid, or is it depressed or completely absent? To really have changes in trigeminal nerve function, which can occur. All these things that I think are little subtle details, which changes everything.
Thank you.
Yeah.
What are some of the differentiators between the GI symptoms and when they should refer to you? Because you said quite often a child will be treated for GI symptoms. At what point should it be explored that they should be referred to you instead?
Yeah, I think those kids, they have headaches that could be like migraines. They have GI symptoms that could be GI problems. They have vomiting that could be GI problems, or the combination of those things could be brain tumor, right? So you're looking at all different kinds of different diagnoses, right, that are on the table. And if the referring provider is hesitant, pediatricians or anyone there is hesitant to get MRI of the brain, I would say get an MRI of the brain. That'd be the first thing I do, and to do that. Now, if they have other symptoms, look for those visual symptoms. They can pop up, right? And so then the ophthalmologist can be helpful looking for the papilledema. But the biggest thing is you just don't want, you send to referring, to a neurologist that wants to treat the migraines, headaches that think they're migraines, or you send it to the GI specialist, think it's this emesis and GI problems, is GI issues, and they're kind of narrowed in their scope and they're thinking along those lines. I wouldn't hesitate to get a CT of the brain. It's fine to get a CT. One head CT isn't a problem. That's not going to cause problems or radiation. Or get an MRI of the brain. Or if there's any kind of other concerns, discuss that with the GI specialist, discuss it with the neurologist, see if they want to do that. But it's going to be, these symptoms are just intractable, right? So it's whatever, the GI doctor is not going to be able to help the GI symptoms. They may help a little bit, but it's just, it's back again, a month later, 2 weeks later. Geez, we still have these headaches, these, migraines. No migraine medications worked, So, and really kind of all the subtle neurological findings, the ataxia. You shouldn't have, if a child's having balance problems and ataxia, that's unlikely to be from GI problems or obviously from a migraine, right? Changes in reflexes, a lot of these things. So those are the kind of things that I would look at, and if there's any concerns, just talk to me about it.
Great, thank you.
Yeah.
It looks like there's a question in the group chat. When should we refer for plagiocephaly? Is imaging needed prior to the referral?
Yeah, so people use different terms for in terms of what they think about plagiocephaly and what it is. So I want to be clear here, and I'll go back to that slide. There's the plagiocephaly that's not craniosynostosis. That's from positional and it's deformational. That doesn't require surgery. And we typically would just either try to reposition the child's head and neck. Oftentimes these kids will present with oftentimes they have this because they have torticollis, right? So their neck is, once it turns in one direction, they always lay back to sleep in the crib, lying on the back part of one side of their head all the time, right? And then some kids that just have a little bit bigger head, it's heavier. And so then it's putting more pressure on it. So then the kids with the bigger heads, the harder to lift their head up, right? So they don't move their head as much. It's heavier. So when they lie down on it, they get more of this kind of deformational positional plagiocephaly. There's little subtle things just on exam clinically that you can look at to determine whether this is deformational positional plagiocephaly or a lambdoid synostosis, which can mimic it. Now that's a little tricky, I think, for a pediatrician. X-rays are kind of the best thing because they can look to see if the lambdoid sutures or any of those sutures are fused. And if there's any questions, then they could always ask me or send the patient on to us, and we'll get X-rays. We'll look at them, or look at the X-rays, with the pediatrician. But usually, deformational positional plagiocephaly can be corrected just with a helmet or just even repositioning. So trying to bumping the shoulder up, trying to keep the head, the kid's lying on it off the side that's being pushed forward, as well as then helping the torticollis, right? That's the ultimate thing. The kid's neck is kind of tight and wants to hold in one position, trying to reposition it so that it's more freely movable.
All right, before we wrap up, are there any more questions? And remember, you can unmute yourself or ask through the chat function as well. Okay. Well, if there are questions that come up after you've thought about it for a while, you can feel free to reach out to any of the provider relations managers, and we can forward it on to Dr. Dlouhy, or you can reach out directly to him. We have recorded this presentation, so you will have the contact information for him and all of us as well. So feel free to reach out at any time over the course of the next weeks, months, years, if you do have a question and a possible referral. But until then, thank you for attending today's presentation with Dr. Dlouhy. We will send you the presentation in a follow-up email. And thank you, and we hope that you have a great day.
Great, thank you so much.